But if not, I can.
Okay, yeah. We have a recorded talk. So we will start the recorded talk. It is on to, but you are here to answer questions. So how to identify
Correct.
and manage spontaneous coronary dissection. So it's an extremely interesting and important topic to talk about. Fahim Jafary.
Ladies and gentlemen, thank you so much for the opportunity to speak here today. Must congratulate Bashir, Zubair Akram, Tahir Saghir, Nadeem Rizvi, and all the other organizers of this conference. It just keeps getting better and better, and I'm certainly privileged to be participating in it. I have only 10 minutes for this talk, and my job is to talk about spontaneous coronary artery dissection, or SCAD, with emphasis on how to identify and manage it. I don't have any conflicts of interest related to this talk, so let's move on. We're going to talk about what SCAD is, what the presentation is, when to suspect it, what the angiographic features are, and what the treatment considerations are. So SCAD is basically blood in the vessel wall or in the media. So that's normal. This is blood or a hematoma in the media. And what this does is it sort of obstructs the true lumen, and as it does so, eventually tears through the intima and results in an intimal tear. It is largely believed that it begins with an explosion in the vessel wall leading to a hematoma, and this hematoma then eventually tears through the intima. And as you can imagine, this will compress the lumen, and the intimal tear in some ways acts like a decompressing force, sort of like when you drain an abscess. And so this one is more risky than this, because at this point the hematoma is draining into the lumen, and so whatever the lumen is, whatever the true lumen is, it's at its worst. And so we worry more about people with isolated intramural hematoma compared to those with a hematoma with an intimal tear. And that's an important concept to keep in mind as we talk about management down the line. Now, when do you suspect SCAD? There are a few situations where your antenna should go up and you should start thinking on the lines of SCAD. When you have not the typical ACS patient, young women in their 30s to 50s, peripartum women, think on the lines of SCAD. Think when you have an unusual trigger, intense severe exercise, intense Valsalva, heavy lifting, particularly in men where it's rare to get SCAD, but when they get SCAD, it's usually in this scenario, severe emotional stress, labor and delivery, retching, vomiting, recreational drugs like amphetamine, etc. And also, when you take the patient to the cath lab for an ACS and you find that everything is very normal except for that one spot, because atherosclerosis is a diffuse disease, think on the lines of SCAD. If not applicable to the usual PCIs. You have to keep those in mind. Hospital care involves a longer hospital stay if you're going to treat them conservatively, up to 6 days, and the future involves the potential for recurrences and the need for additional screening for fibromuscular dysplasia. Ladies and gentlemen, thank you very much for your attention, and I apologize for going a little bit over time, and I'm happy to take any questions if there are. Thank you.
Dr. Fahim, thank you very much for a very comprehensive talk with great clarity on quite a few questions that are often asked. We will come back to you. Please stay with us and bear with us after 3 or 4 talks for question and answer. So everybody, please note down your questions whilst we move on with our talks. Just a request from all the panelists who are on Zoom to mute themselves so that whosoever is speaking doesn't get so complicated. May I request Professor Nouri to come onto the stage as a panelist. Nouri Saab, General Nouri, please come up to the stage. And Dr. Abu Bakr, if you can come on to the stage as panelist, it will be an honor for us. Thank you very much. And Dr. Salman Arai, we have missed your talk, looking forward to it, toolkit in CTOs. So over to you, Salman.
Thank you very much to the organizers, Dr. Bashir, to all the colleagues on the panel, and all the colleagues that I see online. A lot of people are working back in the US. So, I mean, you've seen a lot of CTO cases this morning. I think in some ways this talk is a little late, but hopefully this will sort of round up everything nicely. Can I have something to forward the slides? Next slide, please. So the CTO toolkit in 2023 for those of us seeking to start this program. Okay, good. All right, so the requisites for successful CTO PCI include the proper tools, appropriate skill set and experience, and a well thought out strategy. And all of these things come with time and experience. We've had talks on this before. I'm going to focus on number one, which are what are the proper tools. Any CTO PCI can be divided into three phases. There's crossing the occlusion. This can be antegrade or retrograde. Then there's vessel preparation once you have successfully crossed. And after that, there's definitive treatment. And so a lot of the tools have to do with actually making sure that the crossing is successful, because unless you cross, there is no CTO PCI to be done. So the strategy of what you're trying to do then determines the choice of tools. And so you have tools for crossing. These include wires, microcatheters, reentry devices. You have tools for vessel preparation, balloons, atherectomy devices, intravascular lithotripsy. You have tools for definitive therapy, which in the US we have just drug-eluting stents, but obviously outside the US we also have drug-coated balloons. And then you have adjunctive tools for imaging and support devices. Now I should also add a category number 5, which is tools to manage complications. So for the purposes of this talk, we'll just be talking about tools for crossing and vessel prep, and we'll also then maybe touch on tools for complications. So wires for CTO. Without wires, there is no crossing. This is the essence of any PCI, particularly CTO PCI. There's too many wires to talk about individually, so I'm just going to summarize the points. Wire selection depends on CTO PCI technique. The wires are performed for individual functions. Unlike non-CTO PCI, you can't just have a workhorse wire. You have several wires that perform several specific tasks. These include cap penetration, tracking within the plaque or outside the plaque, septal or epicardial crossing, knuckling reentry. So there's several options for each of these, and I think as a CTO operator, you have to get to use all of them and become experienced in a few of these. Several interchanges are often required. On average, you'll need about 6 to 7 wires for a complex CTO, so that's something you have to get used to, the idea of using multiple wires. Important wire properties that affect choice of wire: there's torqueability, there's trackability, tip load, wire support, and tactile feedback. And it's a difference in these properties that makes the wires different in how they behave within the lesion. All right, so what makes a CTO wire special? The 3 C's. The magic of the wire is at the tip. So you have the core, the coil, and the coating. A detailed discussion is beyond the scope of this talk. However, these are 3 of my favorite wires currently that I'm using, and I just want to put these up there just to show you the differences in how the tips are shaped, how the coil is different, and how the coating makes them have different properties. So you have the Asahi Gladius Mongo, you have the Fielder XT, and Gaia Second. So one of these 3 is typically my starting wire. One of the things that we like about the Asahi wires is the Act 1 core. You can see there's a lot of technology that goes into the wire. It seems like it's one entity, but even within that, you can see there are wires within the wires. All right, so these are my choices. Everyone on the panel here and everyone who does CTOs has their own selection. So this is my selection for microchannel probing. I like Fielder XT, cap penetration Gaia 2 or 3, intraplaque navigation typically Gaia 2, extraplaque navigation Gladius Mongo, knuckling Gladius Mongo. Septal surfing a Scion Black, epicardial crossing Suo, and reentry, which is targeted reentry, is often a CP12 or Hornet 14 or maybe in a Stato. Now, these wires will vary from case to case, but what I want you to take down is that essentially there are 6 wires that I'm using in different combinations. So most of you should be able to come up with a core selection of wires, and that was a question that came up in one of the sessions this morning. Okay, but a wire alone is not enough. You also need microcatheters. Again, you have different brands available, essential for CTO PCI success. They have several advantages over the wire balloon. This is another question that came up in one of the earlier sessions. These microcatheters give you greater flexibility. They provide more support for the wire. Oftentimes they're torqueable. They can sort of drive themselves forward, and they can be used several times. They require good guide support that is essential for success, and there are several uses such as wire exchange, the delivery of contrast and drugs, channel dilatation. Now, specialized microcatheters such as the dual lumen catheters or angle tip catheters also allow you to basically deal with tortuous or complex anatomy. Now, there are several types of catheters. You know, there's a Boston Scientific has their own family. This is from the Teleflex. This is what we have most commonly in our lab. On the top, you have the low-profile version, the Turnpike LP. Then you have the Turnpike itself, which is the more classic. Most of my cases are done with these top two, or the Corsair. Then you have Turnpike Spiral with the externals are blue nylon coil for more grip. That's more for going down and coming, maybe going down a graft and coming back up. And then the Turnpike Gold for some of the more complex calcified lesions. What I want to talk about is what makes these torqueable microcatheters special is the layers. So again, a lot of technology in a one small piece of equipment. You have the PTFE tube, you have the braided nylon tube, you have the two layers of the dual coils. And it's these coils, as they kind of interact with each other as you torque the catheter, that stores the energy and pushes the catheter forward. All right, so how to get the most out of your microcatheter? Adequate support, the guide rails well engaged, ensure that the wire is advanced far enough within the lesion. Alternate between clockwise and anti-clockwise torque if your catheter allows it. Not all catheters allow you to do this. And definitely don't over-torque because you can have tip detachment and tip fragmentation. And then watch out for catheter fatigue because the catheter itself can pretzel and cause trauma to the collaterals. Here's a specialized version, dual lumen microcatheters. The one on top is a twin pass. That's from Teleflex. At the bottom, there's Sasuke. I think they both have different properties. We used both. I like the Sasuke because it's very slick and very deliverable. And here are some of the applications. And again, I'll leave the slide up for a few seconds. But there's several uses to how you can use a twin pass catheter. And it seems that with every case, we can use it in multiple different ways within the same case. All right, here are the angled microcatheters. You can have passive angulation, which are the Supercross family up top, or you have the venture catheter, which actually has a torqueable sort of thing at the hub, and you can use that to direct the angle. I personally prefer the ones on top, and here's a case of us trying to get down sort of an occluded graft and trying to make a retroflexed sort of the wire go back up the RCA, and then you can see how the catheter helps us negotiate that right tight turn. What's really nice about the Supercross catheter is once you have enough wire purchased, you can actually advance the catheter over it, as you can see that, and change out for a more stiffer wire. All right, moving along. Guide extenders, this is to build support. Again, support is key for a lot of these CTO cases. Several brands available in varying sizes, 5 French to 8 French. Now many of them come with a hydrophilic coating, makes them more deliverable. These help you overcome issues of poor guide support. Having said that, you can also do different things by deep seating the catheter, such as exclude hematomas or keep hematomas from forming and allow stents to go through fairly tortuous anatomy. And there's several novel uses. This is what a typical guide extender looks like. Most of them have the same components and different, obviously, specifications. But